If your patient suddenly becomes severely short of breath and oxygen isn't helping the way it should, I need you to think ARDS. Hey everyone, welcome back to PCU Prep. I'm Maya. And today we're breaking down acute respiratory distress syndrome, one of the most critical topics you need to understand for both the NCLEX and PCCN. I'm going to walk you through what it is, what it looks like at the bedside, and what you need to do as the nurse. So stay with me, because this one can get confusing, but I'm about to make it make sense. All right, first things first, ARDS stands for acute respiratory distress syndrome. And here's the simplest way to understand it. The lungs become severely inflamed and start filling with fluid. But this is not heart failure. This is not fluid overload from the heart. This is damage happening directly in the lungs. So now oxygen can't properly move from the lungs into the bloodstream, which means your patient is going to become hypoxic fast. Now let's talk about what causes ARDS, because this is where exam questions love to test you. ARDS usually happens after a major insult to the body. Think sepsis. That's the most common cause. But also think pneumonia, trauma, aspiration, severe infections. So your patient is already very sick, and then suddenly their lungs start failing. And here's the key. ARDS develops quickly. This is not something that slowly builds over weeks. This is rapid, and it can become life-threatening very fast. All right, let's break down what's actually happening inside the lungs. In ARDS, the alveoli, those tiny air sacs, become damaged and leaky. So instead of staying filled with air, they start filling with fluid. And not just any fluid, inflammatory fluid. So now you have two big problems happening at the same time. Number one, oxygen can't get into the bloodstream. And number two, carbon dioxide can't get out effectively. So your patient becomes severely hypoxic, even when you're giving oxygen. That's what makes ARDS so dangerous. Key signs and symptoms. NCLEX Gold. Now let's talk about what you're actually going to see at the bedside. First, severe shortness of breath. And I'm not talking mild. I'm talking sudden and worsening. You'll see tachypnea, rapid breathing, low oxygen saturation that does not improve easily with oxygen. That right there is a huge clue. You may hear crackles, because again, fluid is in the lungs. And your patient may look anxious, restless, or confused, because their brain is not getting enough oxygen. So if oxygen isn't working like it should, think ARDS. ARDS versus heart failure. Now this is where students get tripped up. ARDS versus heart failure. Because both can have crackles, both can have shortness of breath. But here's the key difference. Heart failure is a cardiac problem. ARDS is a lung problem. In heart failure, fluid backs up because the heart can't pump. In ARDS, the lungs are damaged and leaking fluid on their own. Another clue? ARDS patients are often critically ill with something like sepsis or trauma, and their oxygen levels stay low, even with oxygen support. That's your red flag. Keep that in mind for your exams. All right, let's talk diagnostics, because this is where the question might not say ARDS, but you still need to recognize it. First, ABGs. You're going to see low PaO2, meaning hypoxemia. And here's the key. It does not improve easily with oxygen. That's what makes ARDS different. Even when you're giving oxygen, the levels stay low. You may also see respiratory alkalosis early, because the patient is breathing fast. And later, it can turn into respiratory acidosis as they start to fatigue. So if you see worsening oxygen levels that aren't improving, think ARDS. Ventilator support. Now let's talk about management, because most ARDS patients will need ventilator support. And there are two things you need to know. Number one, PEEP, positive end expiratory pressure. This helps keep the alveoli open so they don't collapse. Because remember, these air sacs are already filled with fluid and unstable. Number two, low tidal volume ventilation. We use smaller breaths to prevent further lung injury. Because these lungs are already damaged, we don't want to overinflate them. So if you see PEEP and low tidal volume, think ARDS management. Nursing priorities. Now, let's bring it back to you as the nurse. What are your priorities? Number one, oxygenation. You are constantly monitoring respiratory status, oxygen saturation, and ABGs. Number two, positioning. These patients are often placed in the prone position, meaning on their stomach. And that helps improve oxygenation by opening up more areas of the lungs. Number three, watch for complications. Ventilator-associated pneumonia, barotrauma, worsening respiratory failure. And number four, this is critical, early recognition. The sooner you recognize ARDS, the faster your patient gets the support they need. And that can save their life. All right, Let's test your knowledge. A patient with sepsis suddenly develops severe shortness of breath and low oxygen levels that do not improve with oxygen therapy. What condition should the nurse suspect? A. Heart failure. B. ARDS. C. Asthma. D. Pulmonary embolism. The answer is B. ARDS, because this patient has a major trigger, sepsis, plus worsening hypoxia that is not improving with oxygen. That combination should immediately make you think ARDS. Next question. A patient with ARDS is placed on a ventilator. Which setting is most important to help keep the alveoli open? A. Tidal volume. B. PEP. C. Respiratory rate. D. FiO2. The answer is B. PEEP, because PEEP helps keep those damaged alveoli open, improving oxygen exchange and preventing collapse. That is a key concept for ARDS management. Last question, and this one is about nursing care. Which intervention helps improve oxygenation in a patient with ARDS? A. Placing the patient flat on their back. B. Restricting all fluids. C. Placing the patient in the prone position. D. Encouraging ambulation. The answer is C. Prone positioning, because lying on the stomach helps open up more areas of the lungs, improving oxygenation. This is a high-yield intervention you need to know. All right, let's bring this all together. ARDS is acute lung failure caused by inflammation and fluid in the alveoli. It is not caused by the heart. It leads to severe hypoxia that does not improve easily with oxygen. And it usually happens in critically ill patients, like those with sepsis or trauma. So if oxygen isn't working the way it should, think ARDS. Quick rapid fire before we go. RDS. Lung problem, not heart problem. Most common cause, sepsis. Key sign, hypoxia that does not improve with oxygen. Ventilator support. PEEP and low tidal volume. Nursing priority, oxygenation and early recognition. And prone positioning, that improves oxygenation. Lock those in. And that's a wrap on ARDS. If this topic ever confused you before, I hope it finally makes sense now. Drop in the comments. What topic do you want me to break down next? And if this helped you, like, subscribe, and share with a nursing friend. Next up, we're diving into ABGs, and I promise you I'm going to make that make sense too. I'll see you in the next one.